Thank you very much for your kind introduction, Dr. Sayat. It's a great pleasure for me to be invited to this year's SOS Lymphoma Winter School in Egypt, taking place from the 17th and 18th of February 2022. Greetings from Germany, from Westphalia, and I will tell you and give my talk to you in the next minutes on emerging treatments for cutaneous T-cell lymphoma. Here are my disclosures. So the agenda I will to talk with you are on therapeutic concepts, new therapeutics, and future directions. As you know, cutaneous T-cell lymphoma develops in stages. And there is a huge difference between early stage of cutaneous T-cell lymphoma and late stages regarding the median survival or the 10-year overall survival. In early stage of the disease, these survival rates are almost like the normal population worldwide. However, starting with advanced disease, the median survival drops down beneath 5 years and drops further in leukemic situations like Sézary syndrome beneath 4 years. So there are different approaches for both stages of these diseases between early or advanced stages of the disease. There are therapy concepts and key concepts which we discussed under the experts worldwide. Early stage mycosis fungoides should be treated with skin-directed therapy. In early stage mycosis fungoides, there may be periods of expectant therapy where no treatment is preferred. And in patients with advanced stage mycosis fungoides or Sézary syndrome, systemic treatments may be considered first line. In advanced stage disease, where life expectancy may be severely reduced, allogeneic hematopoietic stem cell transplantation may be considered. A holistic approach to patient care with consideration of health-related quality of life is essential, and symptomatic relief for pain, itch, insomnia, and depression may be needed. So there are basic principles. Avoid cytotoxic therapies as long as possible. Give skincare with emollients, reducing bacterial colonization. Treat additional symptoms, pruritus, for example. Use standard treatments correctly. PUVA and systemic therapies. Think about maintenance treatment and keep in close contact the patient with the physician. In recent years, we performed worldwide a prospective cutaneous lymphoma international prognostic index study, the so-called PROCLIPI project for mycosis fungoides and Sézary syndrome, to get real data how this disease progresses. And we know now that around 6.7% in this study progressed in further stage progression, and 63 out of 1145 patients, so around 5.3%, progressed per year to advanced disease within 1 year of diagnosis. So what are the treatment strategies? And as I said, they depend on the diagnosis and, of course, the stage of the disease. And here they are listed, what we do have today. And these were increased recently in the last 2 years by the topical application in the skin-directed therapies of clomethine gel. And for more advanced disease, new antibody therapies like the fusion toxin brentuximab and mogamulizumab as I will tell you later. But the principle of all these therapy is to avoid, at least in the early stage of the disease, to avoid progression of the disease. And that can be done either by single monotherapy or by combination of various kinds of local or skin-directed therapies, in addition with other combinations like extracorporeal photophoresis or total skin electron beam therapy. And all in the end of these stages, then cytotoxic therapies came into forefront, and maybe crisis as regarded as crisis intervention. The skin-directed therapies are started in the last century, and one of the pivotal investigators were Dr. Zackheim and Dr. van der Heijden with topical steroids and chromatin solution. New is started the last decade in 2013, published by Lessing et al., the chromatin gel compound, a new formulation. They did a randomized study with overall response rate almost reaching 60%. And this was done in the US, and meanwhile, this compound is marketed and also in Europe, and we use it as chromatin gel compound since 2 years. The other one is a bexarotene gel. It's only accepted by in the US and Canada, and not possible and not accepted in Europe as local therapy. The response rates were not regarded enough in Europe to be accepted by our health authorities. And in the recent 4 years, we did a clinical study with toll-like 8 agonists, resiquimod, and the pioneer is Professor Rook. And in the first open label phase 1 study, we saw overall response rate of 75%. However, we performed a phase 2 study, which is not yet published. The results were not so convincing, so we have to think again how to use this compound and how to develop it in cutaneous T-cell lymphoma. So we did a case series in Germany with chromatin gel in 2 German skin cancer lymphoma centers, Ulrike Wehkamp and myself. And our message is the standard therapy is 5 times a week. However, we do not know in advance how which patient reacts severely or intensely on the lesions and who's not. So we have a more conservative approach, starting with initially 3 times weekly. And if the patient tolerates the compound very well, we increase to 5 times weekly. We started now in Europe another study to understand the mode of action of chromatin gel. It's a so-called REACH study, and we will perform patch testing, biopsies to look which patient reacts and do they respond in a faster or different way than those compared to those who do so show no inflammation under the therapy of chromatin gel. But it is an improvement in the local therapy of early cutaneous T-cell lymphoma. What are the current systemic treatments in advanced mycosis fungoides and Sézary syndrome? So this covers the traditional immunomodulators as rexinoids, the bexarotene and the retinoids. the interferon compound. I will tell you something new about the interferon story, extracorporeal photophoresis, radiotherapy, total skin electron beam therapy and local radiation, and antibody-driven therapeutics. HDAC inhibitors are only approved in the US, not in Europe, and chemotherapy, gemcitabine, pegylated, doxorubicin, and CHOP or CHOP-like schemas, and of course, allogeneic stem cell transplantation. Also, here are general principles in the treatment of late stage. Outlining a specific therapeutic concept is mandatory for each individual case. Skin care with antiseptics and emollients to beware the resident microbiome, high caloric parenteral substitution in tumor cachexia, systemic antibiotics in disseminated ulcerative tumors, and trying to stabilize the immune system in certain cases using immunoglobulins, and try to avoid the use of cytotoxic drugs over a longer time period. So there is no right way to treat SS, but there is a wrong way. So delay progression with non-toxic drugs as long as possible, or skin-directed therapy, improves the symptoms and quality of life, and use, of course, systemic antibiotics. An aim for all allogenic stem cell transplantation, looking for suitable patients in first remission or for new clinical studies. So one interesting publication came out in Blood 2014 by the Danish group around Torben Kreisgaard, who showed that staphylococcal enterotoxin are associated with immune dysregulation in cutaneous T-cell lymphoma. These enterotoxins increase the interleukin-2 secretion, the interleukin receptors. They induce phosphorylation of the JAK pathway and inducing immunosuppressive tumor immunity, reducing interferon gamma, the maturation by interleukin-2, and increasing M2 macrophages. And then, in addition to this concept, they published in 2019 in Blood that antibiotics inhibit tumor and disease activity in cutaneous T-cell lymphoma, and they showed it in very nice cases, as you can see here. And the clinical concept and the antibiotic scheme are written down here. Therapy with cefuroxime and metronidazole 3 times daily for 10 days, given EV and oral, followed by oral amoxicillin and clavulan acid over 14 days. So this is very effective as an intermediate concept to treat advanced cutaneous T-cell lymphoma with erosions and ulcerations. And here an example, here heavily ulcerated mycosis fungoides, disseminated stage 4A2. And so we did a complex systemic therapies via antibiotics, immunoglobulin, and parenteral substitution. And then if we more or less epithelialized the ulceration, we added mogamulizumab, and this patient is still alive and doing very well since last years. So the treatment, and in all guidelines worldwide, the treatment strategies are dependent on the diagnosis and the stage of the disease, either also told you, and underlined are the red ones. I will go and discuss with you and what we are doing in every stage of the disease. So something new about interferons, Roche worldwide stopped the production of the old recombinant interferon alpha 2A. However, we did a study, an early phase 2 study, phase 1 to 2 study in 2015, 16, 17 with the pegylated form of interferon alpha 2A, and did a dose escalation study evaluating pegylated interferon alpha in patients with cutaneous T-cell lymphoma. And in this study, we could show that this compound was well tolerated up to 360 microgram. And now I give you an example. This is a patient with T3 tumor and plaques to stage 2B. We started this patient with pegylated interferon alpha. We use low dose interferon to avoid more or less side effects with 135 microgram. This is a second dose and available in Europe and in Germany, giving this once weekly, and then we combine this therapy with classical PUVA therapy, giving 8-methoxypsorelane orally and weight dependent, and do PUVA therapy 4 times a week, Monday, Tuesday, Wednesday off, Thursday, Friday. And you can see the results. The patient cleared totally and is very happy of this therapeutic effect. So this is, the interferon story is old. However, it is reunified in 2022, and I think there we have a lot of potential to use this the interferon together with classical PUVA therapy, as showed by myself in the early in the end of 1999, where we published interferon in cutaneous T-cell lymphoma in one of the hugest randomized trial in cutaneous T-cell lymphoma, and interferon PUVA being the most effective combination therapy we have so far. Another approach is radiotherapy, and there was a change in recent years to low-dose radiotherapy. And as you can see, there are different groups with low dose, either 4 to 9 gray or 2 times 4 gray. However, the outcome is almost the same, over 90% response rates, and a very small number of patients do relapse. So you find here some examples how this works, and here a patient clinical examples, early stage 2B, ulcerative tumor CD4 phenotype. We combine surgery and radiotherapy, and you see the clinical results. This is this patient, older patient, is totally free of disease. Or here in the head and neck with low dose radiotherapy, or here on the upper leg, right leg, with low dose radiotherapy. So in next stage of the disease, in stage 3A or B disease, in the moment we regard TSEB as first-line therapy, either with methotrexate or ECP, 2 treatments 2 times, 2 to 4 times weekly, pegylated in combination with pegylated interferon or with the rexinoid bexarotene. So second and third line therapy are listed on the right. A dear colleague of mine from the University of Münster is Khaled El Sayat, who intensely worked in the recent years on the establishing and of total skin electron beam therapy for primary cutaneous T-cell lymphoma. He advanced this field in recent years a lot with a 6 dual field technique to treat these patients. And he published his results with the low dose versus the conventional dose. And he reached also overall response rates far over 70%. The advantage of the low dose schedule are less side effects, shorter treatment duration, and the possibility for repetition. Here, an example, Khalid El-Sayed kindly provided me this slide from his cohort of treatments. This was an MF with large cell transformation and a female patient, and before and 8 weeks following this total skin electron beam therapy. We know from the Morris from London that the median progression-free disease is also stage dependent. It's over all stages is lying around 13 months, but in higher it tends to the relapses are earlier than in stage 1B disease. So combination therapies are mandatory to keep this favorable results with TSAB. And here an example, TSAB therapy in combination in Sézary syndrome, what we did with interferon plus extracorporeal photophoresis, so crisis intervention, relief of all the symptoms, mainly pruritus, and then trying to keep this result with other kind of approaches. And so we are performing now worldwide a number of therapies which are listed here. In Europe, we started a European study via the EOATC about TSAB plus minus mogamulizumab. So I think we will see how we can increase the effect and the long-term benefit by combining these kind of therapy for our patients. For very advanced disease, like you see here, in this case of an elder female patient, that we can short-term using a cytotoxic therapy like doxorubicin, and this patient cleared, and then going back to non-toxic therapies. This is my recommendation to treat such a patient when you are not, when you do not have antibody therapy possibilities. In the treatment of options in Sézary syndrome, first-line therapy is regarded as extracorporeal photophoresis, old schemes of chlorambucil plus prednisone, combinations, retinoid, backpack interferon, and the new, which is approved as second-line therapy in Europe, is mogamulizumab, and third line is alemtuzumab. I will come on this compounds. For Sézary syndrome, we have a new blood classification to have it more objective. Like B0, we count CD4, CD7 negative cells, or CD4, CD26 negative cells. And cells who are over 1,000 microliter, or 40% or 30% CD7 or 26 negative cells, are regarded as B2 and or the ratio, as already known, between CD4, CD8 lies over 10 is regarded as involvement of the blood compartment and classified as Sézary syndrome. And recently, this updated classification was published by Olsen in Blood in January this year in Blood. The new and already introduced antibody therapies are, and the targets are listed here. The CD30 is for the fusion toxin. The CCR4 is for mogamulizumab, and the KIR is to be addressed by the KIR antibody lacutamab, and T-cell activation markers are also in focus, and I will shortly talk also about PD-1 and PD-L1. There are different others, but the time is too short to talk about all these targets. So I focus on these ones listed here: brentuximab, moga, alemtuzumab, lacutamab, atezolizumab, and dolastatin and brentuximab. Vedotin is a fusion toxin, and this spindle cell toxin is extracted from Dolabella auricularia and induces apoptosis. And the huge randomized study, the so-called Alcanza study, was a comparison from brentuximab vedotin versus physician choice in CD30 positive cutaneous T-cell lymphoma, published 2017 in Lancet, and there were a number of sub-analyses thereafter published in the European Journal of Cancer recently. So the most significant result in my eyes is the progression-free survival rate, which increased to almost 17 months by using brentuximab vedotin. Physician choice was methotrexate and bexarotene. So we have, for the first time, a compound who increases the response for these patients almost 1.5 year. And so the question is this related to the CD30 expression, and how we do the treatment in these patients? Because the fusion toxin, the monomethyl augustan, has one severe side effect, that it is neurotoxic. So we have to really use this compound very carefully when we try to use it for a longer time period. So I give you an example here. This was a CD30 positive granulomatous mycosis fungoides. And so you see here, we did the classical intervals cycle for 3 weeks. The first 4 cycles were in 3 weeks intervals, and then we increased the intervals over time. Totally, he received 11 cycles. You see the PET scan, and you see the PET scan during this treatment that he totally cleared. And we also tried to minimize the cycles by combining the therapy, and which was published in the journal, in the German JDDG in last year, that we combined this patient with a median age of 67 years. And by using additional skin-directed therapies, we could increase the overall response rate and the duration of response in these cohorts. Here, this example, the regression of this information, or here in combination, a patient with disseminated cutaneous T-cell lymphoma, and you see he cleared totally. So a big discussion is about the CD30 expression in cutaneous T-cell lymphoma. This analyzed a great variation, as you can see, and from the Alcanza study, and it made it also difficult in the recruitment. There were some biopsies first time positive, then again negative. So if you want to have a right picture of the CD30 expression, I recommend to you to do 2 to 3 punch biopsies to get an idea how what is about the CD30 expression. And large cell transformation that was shown by Kim does not influence the response of treatment to brentuximab vedotin. However, the group of Julia Scarisbrick showed, if you look at the CD30 expression, of course there are patients with low CD30 expression who showed complete responses, but those who had high response rate, high CD30 responses almost showed complete clearance, and to my experience, this lasted the longest time, and which we showed in our monocentric study, which will be published this year in the Journal of the German Dermatological Society. You see these patients with the highest CD30 count, over 60%, has a longer survival estimate than those with lower CD30 counts. Another major advantage in the treatment of Sézary syndrome is mogamulizumab, a humanized anti-CTCL4 antibody with a defucosylated FC region. It induces a double hit. It kills the malignant T cells and also the tracks. This increases the possibility of autoimmunity. And the largest study was the Maverick trial with over 370 patients, comparing mogamulizumab to vorinostat, and the drug was given in 1.0 milligram per kilogram 4 times weekly, followed every 14 days up to 12 months or progression, and vorinostat was given daily. The results were, and this was also impressive, that the progression-free survival lasted almost 8 months, and the duration of response was around 14 months, but the response rate, important according to the compartment, was in the blood compartment, that almost 70% showed a major response in the blood compartment. And this made this compound very efficient to treat patients with leukemic involvement. Here, an example of a Sézary patient, and you see this before the therapy was B2, and only we started then in August 2020, and in September this patient was cleared. He was then with the FACS analysis B0. So fast responses under the use of mogamulizumab in these patients. So here the example, the redis and the erythroderma and the clearance of this patient. So what we have to know about mogamulizumab, there are infusion-associated side effects in almost 24%, but only few led to therapy interruption. More difficult is the occurrence of exanthema. It's called the mogamulizumab-associated exanthema, it occurs 3 to 5 months later, but after initiating this therapy. And then it's the question, is it specific relapse of the Sézary syndrome, or is it reactive? In most cases, it is reactive. And then one has to look for infections and sepsis. So there is a close monitoring necessary of this patient. And the autoimmunity manifestation in general can occur after half a year of treatment of these patients. Sometimes is of benefit for the patient, and this was experienced and published by my dear friend Martin Bagot, that mogamulizumab can induce autoimmunity with long-lasting effects, as you can see in this patient. And autoimmunity sometimes can be really of benefit to these patients. Another interesting compound, which is now regarded as third line, is T cells and alemtuzumab, and regarding circulating central memory or resident memory cells. And you see these central memory cells circulate, and what CD52 does, it depletes these cells. And so as a third line, one can use low-dose alemtuzumab for leukemic cutaneous T-cell lymphoma, which was published by Rachel Clark. And here an example of a patient. He has a really striking itching, as you can see, and so he was totally relieved by only very low doses of alemtuzumab. But this has to be guided with a close monitoring, so it's very efficient, very cytotoxic to these lymphocytes. And you see the drop within 1 week from 45,000 to 10,000. So this has to be given in guidance, as so far has shown short-term efficacy in some heavily pretreated patients. And it may induce, if one goes carefully around with this compound, induces long-term remission. So it's still worthwhile to be used for these advanced patients. And emerging, what is our hope is lacutamab, a first-in-class cytotoxic inducing antibody, and depleting here T-cell lymphoma tumor cells. And this KIR-DL2 is specifically expressed on cutaneous and circulating cutaneous T-cell lymphoma cells, expressed by 55% of all CTCL patients in all involved compartments, expressed by up to 85% of TTCL patients inserted aggressive subtypes, in particular Sézary syndrome, enteriform macrosis fungoides, and also expressed in NK and T cells, but no other normal tissue. And it's also expressed in peripheral T-cell lymphoma of all types, and in particular acute type of T-cell leukemia, lymphoma. In the first phase 1 study, which was already published by Martin Bagot in Lancet Oncology 2019, shows a progression-free survival around 12 months. And a number of patients, this phase 1 study showed complete remission and durable responses. This drug is not immunosuppressive, which is of great advantage for the further use. And a phase 2 study are now being performed. And you see baseline and week 5, and accordingly the clinical picture. So we have great hope for this antibody, and we are performing the so-called TELOMAC study, T-cell lymphoma anti-KIR therapy. This is a multi-cohort international phase 2 trial, 3 groups: Sézary syndrome, mycosis fungoides, and peripheral T-cell lymphoma. So we are in the center of this study project, and I hope that end of the year or next year we can report on these results. We performed from the EORTC, coming to the next antibody is the atezolizumab, the anti-PD-L1. We performed a multi-center study from the EORTC lymphoma group over Europe in the treatment of stage 2B4 mycosis fungoides patients, relapsed refractory after previous systemic treatment. And you see checkpoint inhibitors have, of course, revolutionized the therapy of solid and hematologic malignancy. And this has two central reasons because competing balance of depleting malignant T cell while simultaneously enhancing an anti-tumor cell response, and concern for tumor hyperprogression by blocking these inhibitory signals on the surface of the malignant T cell, thereby leading to further proliferation of the malignant cell. And preclinical and clinical evidence suggests that PD-1 programmed DEF1 ligand may become an important therapeutic tool in the management of these patients. And we had a study design of 29 eligible patients who received after registration 1200 microgram EV every 3 weeks maximum per year. The primary endpoint was best overall response rate and a number of secondary endpoints. However, we had to pre-terminate the study due to 3 sepsis cases in this study. We treated finally by decision rule per protocol 17 patients and the overall response status within years was success in 3 patients and 70.6%, failure in 80.2%, and the best overall response rate were partial response in 3 patients, or 17%, and stable disease in 7. So these were rather disappointing results from this study. That atezolizumab showed only moderate activity in pre-treated advanced cutaneous T-cell lymphoma. The median number of therapy cycles correlated with response. B2 or LDR did not correlate with ORR. And the main reason for going off treatment was disease progression. And especially high advanced CTCL patients are at risk to develop sepsis. And what we are now doing is further analyze subpopulation to get the idea how atezolizumab works and to know about biomarkers to select more sufficiently patients for checkpoint inhibitor therapy. The response rates from the PD-1 inhibition studies performed by Michael Kodderhaus showed that this expression did not correlate with the expression of PD-L1, the total tumor burden, or interferon gene expression signal. But however, they showed significant anti-tumor therapy with PD-1 inhibition, and in some cases durable responses and a favorable safety profile. However, this compound also is still way to be approved for the treatment of cutaneous T-cell lymphoma. So coming to the last part is the maintenance therapy and then future directions. And we summarize these maintenance therapy concepts with mycosis fungoides or cellular syndrome recently, 2 years ago, in the European Journal of Cancer, which is really a neglected topic so far. So we started years ago a maintenance study with an HDAC inhibitor, resminostat, which modulates the cell phenotype, enhances the NK cell response, modifies gene regulation towards a more increased TH1 response, and reducing interleukin-31 cytokines. So we started with this design, 190 patients with advanced mycosis fungoides or Sézary syndrome, and the patients received 600 milligram on day 1 till 5 every other week, and until progression. And follow-up patients who received placebo, they were switched after progression to the Verum arm and then followed. So the primary objective is to determine whether maintenance treatment with resmetirom increases progression-free survival compared to placebo. There are several other key secondary objectives. So we performed the study worldwide, including Japan, and we have opened more than 40 centers, and we almost closed the study. We have more than now 190 patients. Our goal we will reach in several weeks, and we will report, I think, in 2023 on the results of this maintenance study. Another story, I'm coming back to TSEB and what we can do to also maintain these results. And recently, just months ago, Khaled El-Sayed published the study on low-dose total skin electron beam therapy plus oral bexarotene maintenance therapy for cutaneous T-cell lymphoma. And you can see maintenance therapy increases the progression-free survival, doubled it almost. So maintenance therapy plus TSEB is one of our future projects, and we are also doing it via the EATC with mogamulizumab. So there is a need for adjuvant therapy with skin-directed therapy, supportive therapy. And so you have to think about combinations and to give this holistic approach to the patient. So topical steroids, chromatin gel, radiotherapy, phototherapy, and I remind you on these examples. Don't forget it, especially in early cases of the disease. So this is the concept of maintenance therapy over the stages, and I recommend to do no monotherapy, rather combinations, and keep almost control over the disease. This is most important. We don't know the molecular pathogenesis of cutaneous lymphoma. We don't know what is the key driving force in this respect. There are a number of genes, meanwhile, identified. And so you see here are a chart where you can see a number of compounds which are in discussion to be involved and developed for the treatment of in cutaneous T-cell lymphoma, especially the JAK inhibitors, the dimethyl fumarates, the PI3 kinase inhibitors, and older the proteasome inhibitors or the mTOR inhibitors, but still they are far away to be approved in cutaneous T-cell lymphoma. And this is not so easy. So we have to do NGS workflow, a patient to look for the mutations, the next generation sequencing panel. And for example, in one patient, we sequenced the mycosis fungoides probe with immune TrueSight by using 4,800 genes. We found 114 somatic mutations. And now look on this red underlined genes be detected under these over 100 mutations, PIK3CA, TNF in this case. So this PIK3CA gene is mutated, and these mutations, as we know, go along and induce oncogenic transformation in vitro and inducing murine mammacarcinoma in vivo. And the other one is a strong inhibitor. The TNF-AIP3 is a strong inhibitor of NF-kappa-B activation. Missense and nonsense mutations were detected in classical Hodgkin lymphoma. And so when we now see in those mutations of these genes, then you can hypothesize that NF-kappa-B is hyperactivated. So the normal situation is that the PI3K signaling pathway activates the cytokine receptor, activates ACT and NF-kappa-B. And the counterpart is TNF-IEP3. This inhibits NF-kappa-B. So on the one side, it is hyperactivated, but the repressor is now that the second step does not inhibit it. And if this is mutated, then it is truncated and so does not inhibit RIP1. So based on these facts, first trials were induced by PIK3 inhibitors, duvelisib and copanezilib, and these showed so far moderate responses. However, these patients in these studies were not selected, and only really selection of patients who have mutations in these pathways can be regarded as possible candidates for this kind of treatment, of personalized treatment. So this is a difficulty in the next step for the treatment of cutaneous T-cell lymphoma. So the take-home message is stage-adapted therapy in close contact with the patient. Antibody-based therapies improved CTCL therapy so far and are now regarded as state-of-the-art. Maintenance therapy is an important concept and will be introduced in the next few years. A holistic approach in patient care is necessary, and of course, clinical study will improve the field. So I thank you very much for your attention, and I hope to have given you an overview about what is now standard of therapy and the view into the next steps we will perform worldwide to generate even more effective treatments for our patients with especially advanced cutaneous T-cell lymphoma. Thank you so much and have a nice meeting in Cairo.